Okay, so our next talk is going to be on occupational exposures in veteran populations by Anna, and I think it's going to be really great. And it sounds like we might also have another VA expert joining to help answer some questions at the end. So thank you all for being here, and I'll turn it over to you, Anna.
Hey everyone, I can't see what I look like because I only have Lauren up. So if anything comes up, just pause me or let me know. So I'm one of the R2s. I'm one of the COE residents. So I am mostly at the VA and I worked at the VA prior to medical school. So this is a population that I'm passionate about. So this will be kind of a broad introduction and just, something for us to, when we see these patients, just to keep in mind. We'll talk a little bit about a military history, the importance of it, how often it's actually asked in a non-VA setting, and then just overview of some common exposures and risks in a risk factor for those that have served specifically in combat. So at the VA, our mission and our values are here. Our mission is to care for him who shall have borne the battle and for his widow and his orphan, by serving and honoring the men and women who are America's veterans. We're all connected to the military in some way. I have some friends that have served. I am a first generation immigrant. My family and I are so thankful to be in this country. And so for me, it's just such an honor to serve those who have served. And that's really my connection to it. And then we try to follow integrity, commitment, advocacy, respect, excellence. We always take the time to say thank you to everyone that has served. It really does take a nation to care and honor those that offer their lives for our freedom. And some demographics, there are new ones that are going to be coming out soon. These are from 2014. They were published in 2016. About 1% of the total population serves. Largest cohort of veterans that are alive today served during the Vietnam War. That's going to be 1964 to 1975. So you'll probably be seeing a lot of those veterans. The second largest is about 4 million, and those are peacetime veterans. There are fewer than 500,000 World War II veterans that are still alive today. Their median age is 93, so never age discriminate when you're asking for military history. And then 1 million are 85 years or older. So there are some elderly veterans that may come to your clinic. There are, so the post 9/11 veterans, the ones that mostly served in Southwest Asia, those average age is 37. I know for most of you that seems really old. For me, that's actually my age. So it's just important to remember that they can be a little bit older. About 9% are female, which is really interesting because overall the veteran population is declining. It's declined about 1/3 in the last 18 years. And then this is a figure that was released by the VA that basically shows that this is probably going to keep going down. We see those in the lower corner. We see the Vietnam era vets are definitely going to peak, and then we probably won't see those. Rarely do we get to see World War II veterans anymore. And then interestingly enough, the female veteran population is going to start to go up. So right now it comprises about 9 to 10% of the veteran population. But overall, we think that this is going to keep growing, and that probably it'll be about 17% by 2040. So in about, in the time that we'll be practicing, we're going to see more and more female veterans. So the question is, why is this important? And I think the most important thing is to understand that a lot of veterans actually share care with civilian physicians as well as those in the VA system. 65% of veterans will actually have shared care with the community. So when someone comes in for an intake or I meet a new patient, I always give them a spiel. I think everybody does this in their own way. I say, we're more than happy to take care of everything for you. If there's someone in the community that you see, it's okay if we share, but one of us kind of has to take the lead. And they may say, I only want to see you to keep some of these benefits, or I only want to see you to keep some of these benefits for a few of the items. I mean, it just really depends, but we're more than happy to share care, and a lot of people find that really helpful. We also do a lot of referrals outside of the VA. This can vary for services that are either scheduling far out or specialties that we may not have. What I do on a daily basis, like massage therapy, chiropractor, we only have one acupuncturist. And then if they live far and they want to see a specialist, often I can actually get them in. Like dermatology is a really common one. If they need an insulin pump and they don't want to come to the VA, we can always get them in to see someone in the community. So taking a military history is, it's different than probably the questions that you typically ask. A few years ago, there was a physician who was a Vietnam combat vet. He's a pediatrician, and he published this unasked question. And this was in JAMA, just a piece of my mind. And basically he said that he had never been asked about service. Everybody just assumed he was a physician. He didn't serve in the military. And he says that none of his providers even knew that he was a veteran. And although I know all of us know that war can be very transformative, and serving, it is part of the human condition, and we just have to continue to ask about it. Most people that have come to the VA will actually say that they have never been asked about their military service, so about 63%. And then physicians may not know how to ask, they may not know what questions to follow up with. And a lot of veterans probably won't volunteer that history. It's probably just a lot to go into. I've also talked to some of my friends over that do primary care at Swedish, at PacMed, and also at Group Health Kaiser, and none of them have it in their EMR to ask about a military history. So you ask, your patient is a veteran, Mazel Tov, that's awesome. I'm so glad that you asked, so what now? Just ask them and say, hey, you know, do you get care at the VA? Do you have any service-related connections? And what that means is you'll see they often use the term service-related or service connection. So what we say is that we don't know if your military service or your exposure to whatever it is caused this condition, but we are going to presume that it did, and we are going to give you a disability rating for it. And so every month, veterans will get a certain amount of money for their disability. And then for this disability, they will often get all of their care covered at the VA. So if there's something that your veterans are concerned about, or they want to see if they can get a service connection for something else, or increase their service connection because now they really can't work because of some exposure or because of an injury that they sustained, what you want to do is refer them to one of these service organizations. They're called Veteran Service Organizations, VSO. And there's 4 main ones. So there's the American Legion, there is the AM Vets, the Disabled American Veterans, and then the VFW. And I'm sure you've seen these. I think the more rural you get, the more you see, but there's definitely a few of these, and they have service officers there. And these service officers are specifically meant to meet with the veteran and help get the paperwork in. So just make sure you refer them to at least one of these, and you can just Google them. And then at the end, I do have a slide that kind of summarizes. So if you're like me and take pictures of slides throughout presentations, there'll be a slide at the end that kind of has like all like the main things. And so so don't worry about like anything if you were thinking of jotting anything down. So taking a history, the things that we like to ask is what branch, why does this matter? You'll see a little bit further down, but I would just say in general, anyone that sees combat is definitely higher risk, and you should pay a little bit more attention to them. And then Army and Marine Corps are the highest risk for a lot of these things. They are the boots on the ground. They have higher PTSD, higher exposure to anything that's where they're serving. They have higher exposure to a lot of morbidity and seeing a lot of injuries and a lot of just a lot of trauma. And so I will usually say, is there any trauma that you want to tell me about that you've experienced in your life? I may not do this in the first visit. I've actually found that over the phone, it's a lot easier when I'm doing phone intakes now. I just say, you know, is there any trauma that you want to tell me about? Have you ever suffered from depression? Have you ever suffered from PTSD? Is there anything that you were exposed to? Always express service and gratitude. And, you know, I just always try to tell them, you know, just let me know, we're here to help with whatever you need. So one thing that I want to show you, which will actually be in at the end as well. So if you're on your phone, there is an app called Exposure ED that was created by Dr. Hunt, who will hopefully make it onto the phone call. He's the National Director of Deployment Medicine and Occupational Medicine at the VA. So this is a great just to have kind of in your back pocket in your phone. You can download this app. It looks like this. What it does is it actually gives you exposure, dates and location, and conflict. So if you have someone come in and they served in Afghanistan, you can just pull this up and then you'll know some of the exposures. We'll talk about a few of these today: Agent Orange, burn pits. It has everything there. The best thing about it, and watch my PowerPoint skills, boom, provider tips. That was probably my favorite thing on here. And let me show you. So it gives you the questions to ask and then useful resources and things to communicate if you think there's risk. So that's something that I think is really useful and just an app to have, and you can pull it out at any time you're with a patient. So combat veterans are at higher risk for a lot of things. I will say, you know, one thing that we see the most is that a lot of our veterans will come in and say, I'm service connected for back pain, shoulder pain. And yeah, I mean, you're 40, you're 50, you're 60. Of course, we all have back pain. We all have shoulder pain. But I just want to show you this video, which I think will just give you a little bit more empathy. It definitely did for me, as to why these musculoskeletal injuries are so common and can be really debilitating.
There is a huge fundraising deadline coming up for Senate Democrats.
Political ad. Give me one sec here.
Need your help right now if they're going to need it.
I'm asking you to please donate now.
Well, so this is the gear that every soldier is going to get for deployment purposes from Fort Lewis, at least. Right now we're doing the IOTV body armor, which is an improved outer tactical vest. And that's just the vest
Is this working
itself.
okay?
You have your ESBIs where
Thank you.
they're the enhanced side ballistic inserts, one on each side for too many people were getting wounded on the side where that wasn't protected. And then you have big ones of these in the front and back. With everything on here, it's a good 30 pounds. Okay, so there's that. What about the helmet? Okay, so you have your helmet and cover, which is the 5 pounds itself, with night vision and the night vision mount and the night vision glasses, about another 5, so 10 total when they have everything on here. So you have the goat skin Nomex gloves, and they're glove weight, not very much at all, but they are really improved again. Really good stuff. Yeah, 2 ounces. Okay, so now you have your elbow and knee pad set, and this is the improved one, but it's not even a pound. You know, it's really improved to where they don't even weigh very much. And then we have the revision soft light glasses. There's the sunglasses and the clear insert for shrapnel and everything to keep it out of their eyes. Okay, so this is what they call a flick, which is a load-bearing vest. On each side, we have a triple mag side-by-side pouch. You have 3 magazine pouches, 2 hand grenade pouches, and 2 canteen pouches on either side. And then your IFAC, which is a first aid kit. Right now, it's not too bad, but when you get everything in it, I'm sure it can be about 10 pounds with all the magazines and everything that they need. Okay, so we got the Camelback, and it's a 100-ounce bladder in there with everything on there because they need that. That's a big thing. 100 ounces is maybe 5 pounds. Oh, we have the rucksack too, yeah.
Oh, forgot about
We
that.
have 2 sustainment pouches on either side. We have your frame, shoulder straps, and the waist belt. There's a lot of space in there. Because this is everything that they're taking. They don't need anything else. Clothes, everything. It's all in there.
Works. I'm squid.
I know.
So I think that kind of gave me a little bit more empathy for even the 30-year-olds that come in with back pain and with musculoskeletal. It's a lot. So on average, they can weigh about 90 to 140 pounds, and this is what they're carrying. I have some patients that have been on 3 deployments in Iraq and Afghanistan for 7 to 10 months. So you can imagine what that can do to a body. They do minimal adjustments for different body types, and men and women carry the exact same gear. There's very minimal difference. A lot of the veterans that you will see from the Iraq and Afghanistan war have actually, what they will say is they have the invisible wound, which is kind of the signature wound of this conflict, and that's a mild TBI, essentially, given all the IEDs that they may come into contact with. There's a lot of blasts, there's a lot of head injuries, and so we think that some of these TBIs, some of these head injuries lead to like the second most common risk of combat, which is mental health disorders. And no matter the war, we still see the same injuries come back and the same traumas. Only very few things change here and there. My Vietnam veterans will say that when they arrived on the shores of Vietnam, they were handed cartons of cigarettes. They were always available to them. It was a way to pass the time. It was what everybody did. The military provided it. And now you're telling me I can't smoke. You know, that's something that I'm always really just try to be a little bit more sensitive about, knowing that this is something that was given to them to say, here, enjoy, you know, welcome to Vietnam. 60% are, there's veterans that see combat are 60% more likely to start smoking than non-combat veterans. Those who deploy who may have quit smoking are 1.3 odds ratio higher to actually start smoking again compared to someone that doesn't deploy. And those that have seen combat have a 1.3 odds ratio increase in hypertension, as well as other comorbid cardiovascular risk factors. So the tobacco we talked about, hypertension, dyslipidemia, obesity, diabetes, and not to mention all the mental health disorders as well. So these are interesting little graphics that the VA publishes. Veterans are at higher risk for lung cancer. The most common service-related condition is actually hearing loss and tinnitus, and that has to do a lot with artillery and firing in some of the conflicts, and then blast injuries from other conflicts. I have heard a lot of veterans say from Iraq and Afghanistan that you know, if there's a blast that went off, sometimes their vehicle would roll. So not only is the blast, but then also the trauma after can contribute to that. Up to 36% of mental health diagnoses will be found in all combat veterans. 21% that are returning typically get diagnosed with PTSD. 17% get diagnosed with depression. Suicide rate in the veteran population is actually double than what it is in the general population. That highest risk is actually within 3 years of returning. So we always want to make sure that we pay closer attention to that. And then as you can see for PTSD here on one of the graphics, the Army and the Marines have the highest of any of the other branches. There is a terminology that I wanted to touch on, and it's very interesting. And I'm sure Dr. Hunt can expand a little bit more on this, but essentially there's this term called healthy warrior effect. And in past conflicts leading up to the most recent, all the overall mortality and morbidity in the veteran population was actually lower than the general population. The idea of that was that the healthy warrior effect, that these are men and women who are very fit, who are exercising pretty regularly. They are having all of this screening, so they are healthy people. So in the most recent publishings that have been done on this, the healthy warrior effect, for some reason in the Afghanistan and Iraqi conflict veterans, the suicide protection is gone. So they are at the highest risk of suicide. It's still unclear why. The blasts and the TBIs are thought to contribute to that. Also the prolonged duration of these conflicts and the amount of PTSD. You saw the armor that they now wear and the how they have the side protections. So we're also seeing a lot more morbidity and less mortality in these wars because the armor is so much better. So veterans just have a lot more amputations, a lot more pretty traumatic injuries that they may have not been exposed to before. So next, I wanted to spend time with what I have left to go over some of the exposures, and I can pause for questions now. Is there anything specific now, or we can keep going and do it at the end? Okay, so I'm going to keep going. So first, I want to touch base on Agent Orange. I'm sure many of you have heard about it. The brush and the tree coverings in Vietnam were very, very dense, and it made it really hard to see the enemy, and it made it really hard to continue to advance. And so there were airplanes that would fly over and spray what is now called Agent Orange. It's a herbicide that's used to clear the brush. It worked great. And then about 30 years later, we have now discovered that it may have predisposed veterans to these conditions. Most importantly, I think here we're looking, I always look at prostate cancer, diabetes, and ischemic heart disease. How often do we see this? So if you have a 70-year-old veteran that had an MI, you know, always ask them, are you service connected? I ask all my diabetics, did you get service connection for this? Because why not? Can we say that Agent Orange caused this? No. But what the military does is it says, you know what? You were there, you were exposed. We will make this a presumptive condition and we will compensate you for that. Now, it's hard to remember what they are. So what I do when these veterans come in is I will actually Google VA Health Agent Orange. And what will happen is this website will come on. And it's usually one of the first website that comes on, and it tells you everything that you need to know. It gives you all the different diagnoses. It'll also tell you all the different malignancies that are presumed conditions, and then it'll tell you how to apply. Now remember, you don't have to know a lot, and benefits, so the Veteran Benefit Office and the Veteran Health Administration are very different. They don't talk to each other in any way that a provider knows. So what I tell them and what you can tell them is that go to a veteran service organization. I always say go to a VFW and you need a service officer, and then that's someone that can help them. In the last year, so this is what started within the last year, January 1st of 2020, there is now Blue Water Navy. So now we're, you know, almost 40 years out, and now we are giving any Navy veteran that was within 12 kilometers of anywhere in Vietnam service connection for those same conditions. There are ship lists that are pages and pages long, and they get updated all the time. So what I do is I pull up these ship lists and I say, what ship were you on and what were the dates? Because a lot of the ships have different dates. So you can actually go in and say, yes, you would qualify. No, you may not. But either way, just have them go to their VA or have them go to a local veteran service organization and get a service officer and at least get your name in there. You know, like I said, Agent Orange took 30 years. We're just now doing this Blue Water Navy. So you don't know what's going to happen in the next few years. The C-123 aircrafts, which were responsible for the spraying, because we didn't know any of the effects, were actually in use until 1986 and had traces of the chemical. So even if they were in the Air Force, after Vietnam ended, you know, this is not that long ago, 1986, they may still be eligible. Next, I'm going to bring you a little bit closer to home. Camp Lejeune. I don't know if you have heard of this. I did not hear about this until recently. And to me, this has been just so interesting. So Camp Lejeune is in Jacksonville, I believe, South Carolina. And if a veteran was stationed there with his family, with or without family, actually, I mean, doesn't matter, but his family may have been exposed also for at least 30 days from 1953 to 1987, and this is, you know, still very recent, they may have been exposed to industrial solvents. There really isn't one theory for this. It's probably a combination, but we know for sure that an off-base dry cleaning company was dumping all of their solvents into soil that then was upstream of this base. And so all the water, everything that they showered with, that their kids played in, that they drank, had all these chemical and solvents and benzenes. And in addition to that, there were some underground storage tanks that were buried. So perhaps those may have exposed as well. Like I said, it's probably a combination, but regardless, there were some significant exposures there. As you can see, a lot of malignancies and a lot more that we're seeing in females, because a lot of this was the families that were there. We're seeing infertility, miscarriages, breast cancer, lots of bladder cancer, kidney cancer, all type of aplastic anemia. So, and you can always Google Fort Lejeune or go to that other website and you will see this. And, you know, again, just refer them to get, to possibly get service connected if they have one of these conditions. Next, I wanted to touch base on Gulf War illness. So I'm sure you have heard of this Gulf War illness, also known as Gulf War syndrome, unexplained illness, medically unexplained symptoms, medically unexplained physical symptoms, chronic multi-system illness. And it's hard to know, you know, is this mostly a mental health diagnosis? Is this mostly a medical diagnosis? My understanding is that the two have been going back and forth. The medical healthcare professionals say it's likely just mostly psychiatric. Psychiatric says it's mostly medical. I'm guessing it's probably a combination of both, as is most things. And these are very vague symptoms, but they are symptoms that we have seen in other wars. In World War I, these vague symptoms were actually called soldier's heart. In World War I, it was effort syndrome. In the Civil War, it was called a soldier's heart. In the Korean conflict, it was diagnosed as acute stress reaction. And this isn't just an American phenomena. There are veterans in England that have a lot of reports, and there's something known as the Boer War effect, and that was from the Boer War in England. So this happens in every country, and it's hard to say what it is. It may be exposures, it may be underlying just the trauma from war. I will say specifically in the Gulf War, there were so many sandstorms and so many different chemicals used that some of this is thought to be due to the organophosphates that they pesticides that they may have been exposed to. They would take deep containing repellent as well as permethrin and soak the coverings that they would wear on their face to prevent sandstorms from interfering with their breathing. And so they would spend days, months, years wearing these soaked cloths around their neck. And so could that have caused it? Maybe. We can't say for sure, but we can presume it, which is why they can have a service connection for that. They also took PB tabs to counteract if they had any exposure to nerve agents. And then these veterans got anthrax vaccines and smallpox vaccines, which I'm sure that you've heard may or may not have caused this. As I was working on this presentation, I got an email from my good friend, John Stewart. Here it is, personalized. Anna, I traveled to Washington, D.C. So it was right in time. I was so excited that John wrote me. So John Stewart, who used to do, I forget the name of the show, but a late night show, has been very active in trying to get the first responders of 9/11 some sort of reimbursement or some sort of recognition for being exposed to the sites when they were first there, because they've had a lot of respiratory symptoms. That is very similar to what has been happening in the military. So now he has expanded that to help some of these veterans with burn pit exposures. Reports of this, I would say started probably back in like 2004 is what I could find. Vague respiratory symptoms, but definitely reported. And there have been, the Armed Forces Health Surveillance Center did a report in 2010. They didn't see much. They said they don't know if it's related. In 2011, the Institute of Medicine had expressed some concern about burn pits, and there were all these different studies, but really it's still hard to say, and I'll go over some of the research. So what are burn pits? So my patients, the way that, you know, when I've asked them, the way that they describe it is there is no way to dispose of waste in these countries. So when they raid homes, when they use stuff on the bases, everything goes into this pit and it gets set on fire. There are people who patrol the pit, and then most of their sleeping quarters are usually within a mile or two of this pit. So they are sleeping and exposed to all this burning. Now, this isn't just materials, it is also human waste. There are no bathrooms, so they will, you know, go to the restroom, have a bowel movement, and then dump it in a pit. So there's just so much waste that's all coming up, and this is all air that they're exposed to. It is hard to say, you know, what caused it. Interestingly enough, so a lot of this is symptoms that they've experienced. Before I did this presentation, I didn't know that asthma is actually an exclusion for enlisting in the military. So if you have symptomatic asthma and you're over the age of 12, you actually cannot enlist in the military unless you have a waiver. Now, some people do get a waiver. My understanding is it's not that hard to get, but the waiver is something that they have to go through. So that may deter some people, but there's about 5% of the veterans and those in the armed forces that have served that have symptomatic asthma. So a lot of these people do not have underlying conditions that we're aware of before they go to these countries. There is now a airborne hazard and burn pit registry, which if my patients have symptoms, which we'll go over, oops, sorry, I went a little bit ahead. We will go over a little bit later. You can actually go and have them register and have them fill out, and then they can come and see us. So the Enhanced Particle Matter Survey went and did all this exploring in the region, and they tested all the air, and they did find that most of the sites where these veterans were stationed were above what the EPA deemed safe, which is over 15. And let me just give you this is from NASA. So as you can see, the air quality in Seattle is pretty darn good. And then when you get to Southwest Asia, it's definitely a lot worse. So not only are you exposed to worst air, but then you're also around these burn pits and you're exposed to them a lot. To investigate this, some people have gone as far as to test the cigarettes that are used out there, ask the local rates, everything, and they just have not found anything to really link this together. And these veterans are getting the anthrax and smallpox vaccine as well. So here are some of the studies. I'll go through this briefly because I think we're running a little bit low on time. So this was called Stampede in 2014. It was 50 soldiers that had self-reported symptoms within 6 months of returning that had no symptoms before, no respiratory history. They had a chest x-ray, they had a high resolution CT scan, they had pulmonary function tests, which were all done by the same therapist. So there was no variability in that. And then they had a bronch. There was no definitive conclusion. Most of these people had served in Iraq, 24% had served in Afghanistan, and then 20% were female, mostly were male. So these are the categories of what they were ultimately diagnosed with. As you can see, a lot remained undiagnosed. And then the 7 of 21 that had the abnormal cell counts, so those had either elevated neutrophils or lymphocytes on their BAL. Of unclear etiology. And then the miscellaneous category included vocal cord dysfunction, and one person had asthma with it. One person got diagnosed with COPD, one had a lung nodule, one had fixed airway obstruction, inhalation injury, and isolated air trapping. So kind of varied. This was all after they had deployed. We didn't have any pre-deployment data. What I will say is that when they went back and they had asked these people, what were your symptoms before, during, and after, these symptoms are still real. They are experiencing these symptoms even if they are back from deployment. And some of these were even 6 months back. So then it was like, well, we're not finding anything, but they're still having symptoms. So what can we do next? So next they started to ask them questions before deployment, during, and after. And as you can see in this graph, these people were still having symptoms after. So the second study was over 1,600, all taken from Texas, from I believe it's Fort Hood. I have it written somewhere. But a lot of people got a little bit of, like, some of the debate was, well, these people are more overweight, they're more obese, they're, you know, not like a good representation, they're probably predisposed to this, but hey, you know, they got pulmonary function tests before and after. And again, it was really hard to say. They couldn't find anything that was related. Those that were obstructed prior to deployment had minimal change, and a third had normalized. So it was very confusing. And then there was some discussion of, well, should we test more people since we got less than half back that we had originally tested? And I think they estimated that the cost of that would be about $35 million to do that, to do all these tests for everyone. And so it wasn't something that the military wanted to do. I will say that regardless, these symptoms are happening. So then the one study that kind of changed the turn a little bit was a New England Journal study that actually took 80 soldiers, and 49 had biopsies of their lungs, so open or a vat biopsy, and 38 were found to have constrictive bronchiolitis, diagnosed at the time of study. Their path findings had what looked like toxic inhalation, and some particulate matter with some thickening of their arterial walls. 38 were diagnosed at the time of the study out of the 49 that had a biopsy, and then another 9 were diagnosed after the study, a few years after. Regardless, the Department of Defense did not feel that there's anything that we can do for this. What a lot of people will say is like, well, you know, what are we going to do? They have constrictive bronchiolitis. There's nothing really different we're going to do for it. And we're not, you know, out there doing open lung biopsies on everyone. So hard to say what my lungs look like compared to someone that served. This was worrisome enough, though, that the VA did request, and this was in September of 2018, so about 2 years ago, they requested the National Academies of Science, Engineering, and Medicine to form an expert committee to go over the evidence and give their opinion on respiratory health outcomes in veterans of Southwest Asia conflicts. And this was actually published about 2 weeks ago. So this is like hot off the press. And they did not find, their conclusion was essentially that they didn't find anything. But the symptoms are there. So even if there's nothing there now, then what can we do? Because Agent Orange took 30 years. So we don't know how long this might take if it ever does come out to something that we need to do service connection for. So some veterans can get service connected for respiratory symptoms. Same thing, they need a service officer to do this. This is a really nice flow chart that I thought would be great if you have a veteran that comes in, you find out they're a veteran, you find out they served and they had burn pit exposure. I would go through this. I think a pulmonary evaluation is awesome. And then over here, it does say, refer patient to the VA Airborne Hazards and Open Burn Pit Registry. Refer them, have them fill out the information. It's basically just going through where they were stationed, what they were exposed to, and I think, and what their symptoms are so they can get service connected now or in the future. Overall, I think, I hope you see the importance of taking care of a veteran, and then the importance of having known whether or not they served in combat. These men and women have signed up to give their lives for our country, and I think we owe it to them to do the best that we can for their health. And we at the VA are happy to collaborate. We have a lot of primary care providers available. We have a mental health specialist that's integrated. We have same-day mental health, so they can walk into any VA clinic and get mental health. And then we always have a social worker on their team. combat veterans are at so much higher risk, and then Iraqi and Afghanistan veterans are much higher rate of suicide. So we want to make sure that we ask all the right questions. And then I want to do the summary slide here. So those are the veteran service organizations. I did put an Agent Orange because I think we see that a lot, especially with the diabetes, ischemic, and then the ischemic heart disease. And then that's the app. Here's the algorithm. And then that's what the website looks like that you can go to. If you're just, seeing a veteran and you only have your computer in front of you, you can always just go to that website and it'll tell you most of the exposures and what the what the steps are. Remember that it doesn't matter the war. We may not agree with the politics. A lot of the veterans may not agree with the politics. A lot of the providers may not agree with the politics, but we still honor those who have served. And I think it's important to remember that we do not come home from war, but we come home with war. And that's something that is just a part of them. And so we need to make sure that we know that. So I don't know if Dr. Hunt is here. Was he able to get in?
Yes, I am here, Anna. And just
Thank you for all your help.
Oh gosh, yeah. I just wanted to say this was a terrific presentation and how important it is for clinicians, whether you're working in the VA or outside the VA, to how important it is to remember that veterans healthcare is a little bit different from general healthcare. And unless we know that an individual is a veteran and find out that information on a psychosocial history and get a little bit of sense of what their military service involved, particularly if they had deployments, and remember that it's important. Any veteran that served, it's important to them. And we want them to know that it's important to us too. So that's an important reason to ask. It will help you create a much closer and more effective clinical relationship with an individual if you know more about the important aspects of their life. And in veterans, that means their military service. And it also tells you about certain health risks that Anna has nicely kind of given us an overview for. And also there are benefits and resources available to them through the VA that it's very important if even if they don't get their care through the VA, that they are connected with the VA for those resources and care that might be useful to them. So whatever setting you're going to work in, I hope that you take what Anna says today to heart, and also really incorporate this into your practice, recognizing veterans, identifying them, and making sure they get the care that they need and deserve. So Anna, terrific work. Thank you.
Thank you. Were there any questions?
I'll start with one or two from the chat and then people feel free to chime in. But one question, is there a sense of how different the veteran exposure to burn pits are versus what local populations experience, or how these burn pit exposures differ from other places where trash is routinely burned?
From the research that I read, a lot of the institutions have gone in and have asked the local communities, but I think it's been hard to really get reports of what they're exposed to and exactly if there's a higher rate. I don't know. Do you have a comment on that, Dr. Hunt?
I would just say that, Anna was talking about caring for veterans, and really what we're talking about is caring for individuals whose lives have been touched by war. And so really, whether you're a combatant or a civilian, many of these exposures, many of these traumas, many of these environmental degradations and impacts of war are similar for civilians as they are combatants. So certainly these are parts of the world that air quality is poor to begin with, and it may be even more concentrated in these areas of the burn pits. But as the person asking the question says, that applies to civilians as well. So many of the things Anna was talking about in terms of risk also apply to civilian populations impacted by war, living in war zones. And it's a great question. Agent Orange exposure is another one in the Vietnamese civilian population. Much of what we've learned about the impact of Agent Orange has to do with how it affected the civilian population in Vietnam, which was significant.
An additional question about the increased prevalence of lung cancer among the veteran population. Are there any changes to our standard USPSTF recommendations for low-dose CTs in this group, or do you at the VA follow just the standard USPSTF?
Yeah, did you want to answer that, Anna?
I follow the standard. I always follow the standard. I don't know. I think what I do is if they're like, I like round up a lot to get, but I don't, you know, the more you look, the more you find, but I think they are a higher risk, definitely. I think we're going to see it a little bit less now that smoking isn't as big of an issue, especially, but in the Vietnam vets, like it's pretty impressive because they were, like I said, just handed cigarettes. So they might have smoked, you know, 2-3 packs a day. It was free and it was there and it was something to do.
So even though there's not official, surveillance, let's say, for people with burn pit exposures or for veterans, that differs from civilian or non-veteran populations, having a lower bar for, investigating possibilities is probably a good way of going about it. Even though it's not official policy, you might have a lower bar for getting a PFT or getting a HRCT or something like that for someone for whom you have concerns and has a history of significant exposures.
And just because, and especially in Iraq and Afghanistan, a lot of those studies, the PFTs were normal, chest x-ray was normal, CT scan is normal. And then the biopsy sometimes showed this constrictive bronchiolitis. And even if the biopsy didn't, these people were still having symptoms. So that's why it's important to get them on the burn pit registry, because we don't know what's going to happen in 10, 20, 30 years. And then, just making sure they've had a workup. So at least they have a baseline.
This goes back to Anna's comment also about healthy warrior effect. Many veterans will have hearing loss or hearing that's just in the upper, lower ranges of normal. So, and yet when they went into the military, due to the fact that they were healthy, young, they may have been a person that had, above average hearing, let's say. So, and it may be true for some of these other effects too, pulmonary effects. They may have, been very healthy in terms of pulmonary functioning, healthier than a normal person when they went into the military, and now they're sort of just like a normal person, but for them, there's been a significant detriment in their pulmonary function, let's say.
Great, thanks for all those responses to the questions and such great points. We are going to take a 5-minute break and then we'll come back for our last talk. Thank you again, Anna, and thank you, Dr. Hunt, for joining us.
Thank you, Dr. Hunt.
So we will see everyone back here in 5 minutes, so 10:47.